Good afternoon, everyone, and thank you very much for not only coming, but being here at the appointed time. I appreciate you being here. My name is Dr. Monica Sweeney. For those of you who don't know me, I am Chair of Health Policy and Management, Vice Dean for Global Engagement in the School of Public Health. And before I do anything else, I would like to just ask our interim dean, Dr. Julie LaRosa, to come to the podium for a minute and greet you.
Greetings, everyone. I'm Judy LaRosa, and I want to thank very much Dr. Monica Sweeney for arranging this and for inviting our very interesting attorney. And you may have other titles besides attorney for doing this, because I think this is a crucially important topic that a lot of people, as you well know, we don't want to talk about, but we want to talk about. So I thank you, and both of you, so much.
And thank you.
No, I didn't do it.
May I ask everyone to do what I just had almost forgotten to do, is either turn off your cell phones or put them on silent. So we're here today to talk about something that there are a few things that we can avoid in life: taxes and dying. And we have very little choices that we can make with taxes. But we should have choices that we can make about what happens to us. And what we're really talking about, everyone likes to give it a different name. It depends on which side of the issue you are on. But we're going to learn how to talk about it the correct way. And that is supporting patient autonomy. And supporting patient autonomy means that patients should have the right to say what medical care they will accept and won't accept at the end of life. I've worked in many places in my 40-some years of being a health professional, and I think if you haven't heard people referred to as vegetables, oh, the woman in that bed is a vegetable, well, some people don't want to get to the point in their life that they're referred to as a vegetable, and they should have a choice. And having the choice doesn't mean you choose it. It means the choice is there if you want it. So I'm very happy that we have a very experienced lawyer on this subject. I heard her before and I said, I don't know how I'm going to do it, but I want you to come to Downstate, the first time I met her. And when I saw her a second time, I said, I'm still working on it. I want you to come to Downstate. So it's a pleasure to introduce Corinne Carey, who is the New York campaign director for the national nonprofit Compassion and Choices. She's a lawyer who is specialized in public health and privacy, and though she lives upstate near the Capitol, she's a Brooklyn native and a graduate of SUNY Buffalo Law School. So we claim her on many counts. When you're a Brooklyn native, let's give her a Brooklyn welcome to let her know how happy we are that she is here.
Thank you. Thank you so much, Dr. Sweeney, for having me. My job takes me all over the state, from Buffalo to here in Brooklyn, from the North Country to Long Island. And I really think that this topic deserves robust public discussion, and allowing me to come here and talk to you all today is part of making that happen. Let me get myself situated here. You know, most of us have had occasion to think about death and dying. Maybe because you've experienced the death of a loved one. Maybe it's because of the field that you've chosen to enter. And maybe you've even asked yourself, how do I want to die? It's a jarring question, but when most people consider it, here's what they think of as a peaceful death: to be at home with loved ones, to have their pain and comfort managed, to have their spiritual needs and values respected, and without being a devastating burden on loved ones. Those answers were published in the Journal of the American Society on Aging in 2015 when they did a survey of how people envisioned their own death. But sadly, few people are granted this kind of death. In fact, 78% of people die in a hospital or in a nursing facility. Data from a 2012 CDC report shows that most of us will die from a terminal illness, Here are some of the major categories of the causes of death. In a large number of these cases, the dying process is bound to be prolonged with lots of stages of decision-making opportunities and changes in the quality of life. And there's a lot of time for your priorities to change during these periods. The point is that most of us are not going to die suddenly or in our sleep or having sex, which is another answer that some people give. Really terrible for your partner when you think about that. But from the time of the initial diagnosis to the time of death, many decisions have to be made about the levels of care that people want, and at times when we may not be capable of making our own decisions. So how do we ensure that at every stage we're getting the care that we want? It is actually said that death is the great equalizer. No one escapes it. Death comes for everyone. But we know that even in death, we're not all equal. Death comes too soon for those without access to quality, affordable health care, but there are also great disparities in how we experience death and dying, and this slide actually shows some of those disparities. Compared to 67% of white people in the US who have an advanced directive, only 36% of African Americans actually do. The vast majority of those who take advantage of hospice care are white. African Americans are far more likely to have their pain underestimated, have their pain undertreated, and they're less likely to receive adequate pain medication. One thing we know is that if we don't make our wishes known in advance, if we don't have control over the kind of health care that we want, other people are making decisions for us. And that rarely ever turns out well. So, despite astoundingly advanced medical interventions that appear to be miracles, there is no miraculous cure for mortality. I know I've actually thought a lot about this question, how do I want to die? I've thought about it a lot more in the past 3 years since I sat by my own father's bedside and helped him through his painful and frightening, but mercifully quick death of lung cancer. My dad was a Catholic, and he was a tough guy. He was a Marine. And he didn't even want pain medication at the end of life. What was important for him was to be at home with us, and suffering was actually an important part of his death. He, as I said, he's Catholic, and he actually believed in the redemptive power of suffering. By most accounts, I think he had a good death. He died at home with his family 36 hours after hospice came in to help us. He was in pain, but it didn't last very long. He had a dignified death because he died on his own terms. Modern medicine can save bodies that have been beset by untimely accidents and diseases in ways that we couldn't have imagined 100, 50, or even 25 years ago. But it also has the ability to keep bodies alive well past our expiration dates, sometimes seemingly indefinitely. Intensive medical interventions escalate, and people die in places and ways that they wouldn't choose. There is a vibrant discussion in this country about end-of-life care with an increasing focus on patient-driven care and autonomy, and prompting many Americans to think about the kind of care they want or don't want at the end of their lives. Over the past 3 decades, we've experienced tremendous growth and expansion in hospice and palliative care services. And in the 1990s, states in this country adopted laws to allow people and their medical proxies to withdraw life-sustaining treatment. The time has come for another advance in end-of-life care, allowing people to request medical aid in dying when they're terminally ill and want the autonomy to die in their own way. Medical aid in dying is a medical practice where a terminally ill, mentally capable adult with a prognosis of 6 months or less may request from their doctor a prescription for medication that they can choose to self-ingest to bring about a peaceful death. As Dr. Sweeney said, the practice is known by a number of different names, often depending on what side you fall down on. Some proponents refer to it as death with dignity, some opponents refer to it as assisted suicide, and I'll get to that suicide point in a moment. But I'm here today to talk to you about our work to authorize medical aid in dying in New York, to provide you with information about the legislation that's pending in Albany, and to answer any questions that you have. so that we can come to a common understanding about what this bill would do. This discussion is important because too many New Yorkers feel that they have little control over their death when a terminal illness has taken over. Too many endure unrelenting pain and suffer needlessly at the end of life. And far too many take their own lives in horribly violent ways because options aren't available to them under our laws. Medical aid in dying is pending in the legislature. It's called actually the Medical Aid in Dying Act. It's the most neutral way that I think the sponsors could title a bill like this. In some states it's called a Death with Dignity Act or an End-of-Life Options Act. But New York's legislation has the same core protections and follows the same model as Oregon's law, which was passed first in 1994, and in every other state that has since authorized the practice. I'll go through some of these. There's a lot of safeguards, over a dozen of them, but the terminal illness needs to be confirmed by 2 doctors. There needs to be a 6-month prognosis. The person has to be capable of making their own medical decisions, and they have to be able to self-administer that medication. So I won't read all of these, but you can see neither age nor disability by themselves qualify for someone being able to receive a prescription. Someone can rescind the request at any time and in any manner. If a doctor has any doubts about the person's mental capacity, they have to be referred to a mental health professional, and they have to be counseled on all other feasible treatment options, such as pain management, hospice, and palliative care. Perhaps most importantly, no physician is required to participate. So once a medical aid in dying law is authorized in this state, no patient would have to take advantage of it, and no doctor would have to provide the prescription if they didn't agree with it. Because of these strict safeguards, in the 20 years since Oregon first authorized medical aid in dying, there has not been a single instance of abuse or coercion, nor has there been in any of the 8 other jurisdictions and 7 other jurisdictions that now authorize medical aid in dying. The reality is that the District of Columbia, Oregon, and 6 other states have safely utilized this medical practice for a combined 40 years. In fact, according to the 2007 Journal of Medical Ethics, the Oregon's Death with Dignity Act shows that rates of assisted dying in Oregon showed no evidence of heightened risk for elderly, women, the uninsured, people with low educational status, the poor, the physically disabled or chronically ill, minors, people with psychiatric illnesses. It just has had no adverse effect on these groups. And this is something that people feared 20 years ago when these laws first came into effect. More recently, Disability Rights Oregon, the watchdog group for people living with disabilities in Oregon, testified that it has not received a complaint of exploitation or coercion of an individual with disabilities in the use of Oregon's Death with Dignity Act. There has not been a disciplinary action against any physician for practicing medical aid in dying, and data from the Public Health Authority in Oregon shows that people experience a sense of relief, a reduction of fear, and peace of mind when they get the prescription. In addition, Oregon's medical aid in dying law has helped spur the state to lead the nation in hospice enrollment, according to a report published in the New England Journal of Medicine. More than 40% of terminally ill patients in Oregon were enrolled in hospice in 2013, compared with less than 20% in the rest of the United States. Nearly 2/3 of Oregonians who died in 2013 did so at home, compared to less than 40% of people elsewhere in the nation. Research actually shows that 85% of people say that they want to die at home. This is important because one of the arguments that opponents to the legislation here in New York make is that New York actually severely lags behind the nation in utilization of hospice services. With only 28.7% of Medicare enrollees dying on hospice care in New York, compared to 44% nationally, many New Yorkers lack access to quality end-of-life care. For those that do access services, New Yorkers are typically referred much closer to death than in other parts of the country. Just like my own dad, we got hospice in 36 hours before he passed. They were a tremendous help to me as the primary caregiver, but my dad didn't get to experience much of the benefit of hospice. And this isn't for lack of funding. I think it's more about providers and families not wanting to give up. And I think many people see accessing hospice as giving up. And it really isn't. And as far as palliative care, you can access palliative care at any point during that time. And many people eschew it because they think that means that they're giving in to death. New York actually ranks consistently among the lowest in the nation in terms of timely access to hospice, but also the quality of palliative care. According to the most recent reports from the National Hospice and Palliative Care Organization, all of the states that have authorized medical aid in dying have reported improvements in other end-of-life care. The National Center to Advance Palliative Care issues a report card every year on the quality of palliative care delivery. And in all 4 of the states that had authorized aid in dying at the time that this report was issued, all of them received a grade of A. New York came in with a B at 78.1% out of a scale of 100. Well, I was a teacher. I don't know. That seems like a C to me. But in any case, I think we can do better here in New York, and we have to. We now have data from Oregon and California, Vermont and Colorado to help inform the debate here in New York. And I want to tell you a little bit about what we know. First, few people actually use the law at all. Over the 20-year period in Oregon, you can see here that only 1,967 people received a prescription and only just over 1,200 passed away after taking the medication. That means that in Oregon, 35.2% of people receive the medication and then never take it. They die of other causes. And what's happening here is that people just want an option. There's a play called Exit, I think it's called Exit. It's this idea that there's no way out. And when people know that there's a door, it opens up their ability to live the rest of their lives. In some cases, people report being more willing to enroll in clinical trials, undergo immunotherapy treatments, try one more round of chemotherapy or radiation to prolong their lives, because they know that if it gets too bad, there's a way out. Across all of the states that now have reported data, just about 25% in all of these states never take the medication. Family members and providers describe that just having it provides relief. No longer afraid of dying in intractable pain, patients are able to focus their energy on living the last of their days to the fullest. One of the things that we hear from states like Colorado and Oregon and California is that many, many, many people are talking to their doctors about this option. Even fewer ask for it. Even fewer complete the process of applying and making the oral and written request for the medication. Fewer receive it, and then, as I said, a tiny amount of people actually take it at the end. So it's an extreme funnel effect that's having profound impact on the conversations that doctors are having with terminally ill patients. In all of the authorized states, the picture looks pretty much the same. The majority of those who use medical aid in dying had cancer. That's close to 90% in most of these states. They're already enrolled in hospice, and the vast majority of them are able to die at home. Some of the other diseases that people have, or terminal illnesses that people have at the end, are neurological diseases like ALS and COPD. That's another big category of people who avail themselves of these laws. So when such a small percentage take advantage of the law, why is it so important to authorize the practice? It's because passing aid in dying laws actually improves end-of-life care for everyone. Last summer, there was an LA Times article with the headline, "There's an unforeseen benefit to California's physician-assisted death law." It may have been unforeseen to some people, but for those of us in this movement, we know that these laws promote conversations, more open and honest conversations. And what this reporter found in talking to providers in California 1 year after the law went into effect is that physicians across the state say the conversations that health workers are having with patients are leading to patients' fears and needs around dying being addressed better than ever before. They say the law has improved medical care for sick patients, even those who don't take advantage of it. According to a 2015 article in the Journal of Palliative Medicine, the Oregon Death with Dignity Act may have resulted in more open conversation and careful evaluation of end-of-life options, more appropriate palliative care training of physicians, and more efforts to reduce barriers to access hospice care. They've seen increased hospice referrals and reduced potentially concerning patterns of hospice use in the state. This body of evidence is why the number of professional associations have endorsed the practice across the country has grown in the past few years. Many leading medical health groups have endorsed medical aid in dying, including the New York State Academy of Family Physicians, the American College of Legal Medicine, the American Medical Students Association, which is the future of the AMA, the American Medical Women's Association, the American Nurses Association in California, the American Public Health Association, and the Gay and Lesbian Medical Association. It's also why 10 state medical societies have dropped their opposition to aid in dying laws, many of them in the past 18 months. New York is not among those, and I can answer questions about that at the end of this presentation. But objections to the legislation persist. Some of these objections were raised in testimony from the president of the New York Medical Society at a hearing held on the bill just last week in Albany before the New York State Assembly Health Committee. One objection made by MSNY was that patients lose trust in physicians when medical aid in dying becomes a legal option. The research shows otherwise. Experience in Oregon has shown that doctor-patient relationships are enhanced when we engage in conversation with terminally ill patients about how they want to die. Researchers have suggested that Oregon's consistently high rating and quality and usage of hospice may be due in part to more open conversations. A random survey of adults in the US published in the Journal of Medical Ethics asked, if doctors were allowed to help patients die, would you trust your doctor less? Between 65 and 80% of people answered that they would not trust their doctor any less. And a 2001 study from Oregon concluded that ruptures in the doctor-patient relationship were more common if physicians were opposed to medical aid in dying. Earlier studies of people in Iowa and Massachusetts, oncology patients, showed that the majority felt physicians who participated in medical aid in dying were trustworthy. MSNY's president also raised questions about the ability of doctors to deliver an accurate prognosis. Recall that medical aid in dying laws, including the bill pending here in New York, require that someone be within 6 months of dying and able to make their own medical decisions. The claim that doctors are bad prognosticators in the face of a terminal disease is misleading. There is an art to prognostication, and if anything, doctors are much more likely to overestimate a patient's length of survival than to underestimate it. A study of physicians' prognostic skills showed that 63% of doctors tend to overestimate survival by 500%. Discomfort or lack of training in discussing death, a view of death as failure, and a doctor's emotional connection to the patient may all contribute to overly optimistic prognoses. We all know somebody who has outlived a prognosis. I think I mentioned that I'm Catholic. If I didn't believe in miracles, it would be hard for me to have that faith. But the fact is that there is an art, and people generally themselves know when they're entering the final stages of death and dying, and we have to trust those patients. Others claim that the bill has too few safeguards. However, too many safeguards would make it difficult, if not impossible, for terminally ill patients with 6 months or less to access the law. The last thing that we want to do is to pass a meaningless law that cruelly promises dying people unobtainable relief from unbearable suffering. I'll give you 2 examples. Washington, D.C.'s law took effect 14 months ago, but the Washington Post recently reported that not one terminally ill adult has been able to access it, even though district officials estimated about 10 people would do so in the first year. There are administrative rules which are too burdensome and complicated for both doctors and patients. In addition, Kaiser Permanente Southern California published a report in March in the Journal of the American Medical Association showing that about 1/3 of terminally ill Californians who requested medical aid in dying either died before completing the process or were too ill to complete it. It's worth noting that the Kaiser report also showed that about a fifth of the people who requested medical aid in dying didn't qualify to receive it, demonstrating that these core safeguards, all of the requirements that come with an aid in dying law, actually work to screen out people for whom it's inappropriate. In reality, though, most of the objections to this bill are based on fear. Back in 1994, New York's Task Force on Life and the Law issued a report recommending that New York not authorize aid in dying. And the arguments put forth by the task force are almost identical to the ones that we hear today from opponents. That vulnerable people, those living with disabilities, the poor, people of color, and those with illnesses too expensive to treat, will be endangered. That laws once passed are likely to be extended beyond those who are terminally ill. That funding for and attention to improving hospice and palliative care systems will suffer as more people choose aid in dying instead. 20 years hence, and none of these feared outcomes, which were valid concerns at the time that the task force published its report, none of these have come to pass. But opponents repeat them as though we had no data that showed otherwise. They appeal to a politics of fear in urging lawmakers and voters to oppose the measure. But we've seen what the politics of fear have done. They jettison good public health policies, and they have in the past. I'm sure you all remember the debate around the Affordable Care Act. However you come down on the Affordable Care Act, that it went too far, that it didn't go far enough, I think all of us can agree that the invention of the death panel, which killed a really important provision of the Affordable Care Act, was all based on fear. All the provision would have done was allow providers to put a code in so that they could be reimbursed for having discussions with people about the care that they wanted at the end of life. And it was twisted and magnified into a panel that would tell our grandmother whether she could live or die. So we've seen this before. Reasonable minds may disagree about whether medical aid in dying is the right choice for them. But no one's personal beliefs should prevent others from gaining access to this option. The fact is, we should all be able to make end-of-life decisions that are consistent with our own faith and values and beliefs. And for this, I take my guidance from George Carlin, who said that religion is like a pair of shoes. Find the one that fits, but don't make me wear your shoes. I actually think that Governor Jerry Brown, who's a practicing Catholic and the governor of California, said it best when he signed that state's end-of-life option law into effect in 2015. He said, "In the end, I was left to reflect on what I would want in the face of my own death. I don't know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I wouldn't deny that right to others." I look forward to the day when our own governor signs an aid in dying law, and I hope that some of you in this room will join us in that effort. I've got some literature on the table and also a petition, and if you feel so inclined after hearing some of the questions and answers, I would love to have your support.
Thank you so much. No, don't say.
Okay.
You're going to be working some more.
Okay.
I really appreciate the presentation, and we are going to have Q&A. What I would ask is that people who get their questions answered to not come back a second time until everybody has had a first time. And I'll let Corrine call on you. I don't need to be an intermediary. I just want to acknowledge what you said about all of us have had experiences with people who would wish they had a choice. I had an aunt to whom I was very close, and when she was dying in the hospital, she said, "I'm not afraid of dying, but I can't take this pain any longer. I would rather be dead than to have this pain." So there are lots of reasons why people want to make those choices, and there are other people who don't. And if you don't want to exercise the option, that's okay. Just what Governor Brown said. So please ask your questions. We don't have time for another lecture, so make sure your questions are brief so that everybody can get theirs answered. Thank you.
Yes.
First of all, thank you very much for this very moving presentation. My guess is that a lot of people in this room, I'm speaking for myself, but I think a lot of people are very much in favor of this. Where's what's the advocacy that's going to be most effective in getting this through the legislature?
As I mentioned, I think the question is what there might be a lot of support in the room for this kind of legislation. Where's the advocacy needed? What do we need to do to make it happen? And I will say that there is some robust and very well-funded opposition. You might imagine it comes from the pro-life community. The New York State Catholic Conference is the biggest group out in front on this issue. There are some concerns from the disability rights community as well. I think what needs to happen is that people who support medical aid in dying, support the choice, need to let their own representatives know. I do this talk a lot across the country, and if I asked each of you who represented you in Albany, I could almost guarantee that most people don't know. You know your city council person, and you know Schumer and Gillibrand in DC, but I think people forget that there's a state government that actually makes most of the decisions that impact our everyday life. But there is a search engine on the legislature's website where you can find out who represents you. I will tell you that there is some pretty strong opposition in the legislature from lawmakers right here in Brooklyn. So if you live in this area, if you live on Long Island, chances are that you've got a lawmaker who really needs to hear from you. So we let people know about advocacy opportunities. If you sign up or if you just give me your card, I'll let you know. Tomorrow, the New York State Assembly is holding its second hearing on the Medical Aid in Dying Act at 250 Broadway. And so I think there is a slate of over 65 people who are going to be testifying. It's going to be a long day, but lawmakers are going to hear from people on both sides of the issue tomorrow.
Over here.
Yes.
Thank you again for that talk. On that related note, actually, do you feel that the purported breakup of the IDC enhances the chances of this legislation at all?
So the question is whether I think you said purported breakup. Yes. Smartly said that because it goes back and forth almost daily. But many of you may know that there were a group of, I think, eight Democrats in the state Senate who formed their own independent Democratic caucus and caucused with the Republicans. And it basically gave them power over the chamber for the past number of years. And the IDC has recently rejoined the Democrats, who still don't have a numerical majority because you've got this guy, Simca Felder, who conferences with the Republicans also. So it's about the balance of power. And it all may sound way too political, but it has huge implications because the chair of the health committee in both chambers controls the agenda. And that's why we may see the bill move in the Assembly, but in the Senate, we've got a staunch opponent in my fellow Catholic Senator Kempenin, who is not interested in moving the bill through the Senate Health Committee. If, after November's elections, the Democrats take control of the Senate again, we'll have a new Health Committee chair. And if it looks like what it did when they briefly had power in 2010, that person is a supporter of this bill, and we may see it move quicker. So, yeah. But the bill also has bipartisan support. I can't tell you how many offices of really conservative men in the Senate have just broken down in meetings with me in their office on this bill because of a personal experience they had with death and dying. And some of the most progressive pro-choice people in the Assembly remain opposed because they haven't grappled with some of this fear yet. So it's surprising, yes.
There are people who are going over there to sign because they think that the list that's there is for signing the petition, and it's really for volunteering. So do you have the petition so that it can go around so that people won't sign over there thinking they're signing the petition?
Well, that is the petition. There's a box that says if you want to volunteer, check. So just don't check the box. That's the petition. It was the petition we used for the state fair, but I'm kind of a miser, and so I reused them. I crossed out state fair, but it's the petition language. Yeah. I just like to save money, so thank you for being understanding of that. Yes.
So in order to choose where it is okay, you have to be competent. So healthcare proxy doesn't work for that.
No, you can't delegate this decision to
And
anyone.
there's nothing on an advance directive to indicate that.
And you can't put it in your advance directive either. I mean, there are other things you can do. Aid in dying is one small solution to one particular problem. We know we've got a crisis in how we deal with end-of-life care, particularly with regards to dementia and Alzheimer's. But there are some other developments in that area. So, for example, someone can complete an advance directive that says that they don't want treatment if they should lose the capacity to make their own medical decisions. And what does that mean? Well, I was giving this talk in the Capital Region, and a woman stood up and she said, "My mother did that." She put a provision in her living will that said that if she develops dementia, she doesn't want to receive any treatment. And she did indeed develop dementia. Her mother had and her father had, and she knew what that looked like. But then she developed an infection, and she went into the hospital. And the doctor called her daughter in and said, "You know, your mother has this in her living will. Do you know what it means? It means that if we don't treat her infection, she's likely to die within days." And her daughter said she felt like her mother had given her a gift. So there are things that we can do. They're just not medical aid in dying. It has to be for someone who's capable.
Directive is a good start, right?
It's true.
I do clinical ethics here. I'm the card-carrying clinical ethicist, and I often ask a room of people like this how many people have done an advance directive for themselves, and inevitably, in a room full of healthcare providers, people are looking at their shoes. So this was a terrific talk, and I think what's one of the things that's most important is the relationship between medical aid and dying and all of the other things, and the fact that people, when they're comfortable that they have this option, often, don't use it, but that other things kick in, like palliative care, And the fear factor, New York is long lagged behind. It took us 17 and a half years to pass a surrogate decision-making law in this state. My colleague, who's an attorney, said if it had been 6 months longer, it could have voted for itself. But fear is, I once did an ethics consult for a person who was clearly in the end stages of life and had 2 nieces and a nephew who were her surrogate decision makers. And the nieces had struggled but come to a decision for a DNR, and the nephew appeared out of the blue and said, no, I care about my aunt and you're a death panel. And showed up with 5 recording devices on his belt for the ethics consult. Wow. And I had to think about what I was going to do about that. And I just said, I'm going to do what I would do anyway, And so the fear is huge. And the propaganda, I'll use that word, on the other side capitalizes on that fear. We're going to pull the plug on grandma, we're going to, and that's just not what happens.
I think that's true. The propaganda, as you say, on the other side is intense. And at the hearing last week, there was a whole group of people who had no to assisted suicide stickers on their shirts. And 2 of them, after the hearing was over, came to our table and said, we changed our minds. We were given the wrong information about what this bill would do. And we find that over and over again. The polling even shows here in New York, 77% of New Yorkers responded immediately that people should have this right. And then when opposition arguments were explained and the provisions of the bill were explained, that number grew to 81%. So it really is an overwhelming number of people across all faiths and all political persuasions.
It's also about empowerment, and I say that to when I teach medical students about teaching patients about advance directives. We tend to think of checking off the things we don't want. But it's really about empowerment, which I think when you deal with a community, as we do, that's used to being denied things by the healthcare system, talking about empowerment is really important. And sometimes empowerment means saying no to something, rather than saying yes to something. Because we have people who are used to being denied high-tech, expensive medicine, and they see this as, oh, well, I want all these things. They're now going to offer them to me. Well, maybe you don't want them. you know, and so empowerment and education is really important.
That's a good point. Yes.
Do you have a list of position on this bill by legislature?
I do. There are 213 of them, so the handout would be quite long. But if you are interested in any individual's position on this, I can certainly answer the question. We don't generally print them out. We're not at a point in this campaign where we're going after people who are opposed. I know for a fact that there are some lawmakers who are holding up the passage of this bill on the Health Committee who are having some pretty intense personal struggles over this. And so it's not the kind of campaign where you name and shame people who are against this bill. I think, as some people in Albany say, the legislation has to marinate. And my organization is about compassion. So I actually have a lot of compassion for people who oppose this. I'm not interested in doing a 17-year battle like they did for the Family Healthcare Decisions Act, but this legislation is 3 years old. And so we're going to give it a little bit more time before we start calling people out. But I can definitely answer individual questions about where people are. I've got this back here, and then I'll come. Yeah.
I mean, how do you see the role of healthcare providers of all types after the prescription is written? Because after the medication is given to the patient, what is the role of a physician, a social worker, or a nurse, or the patient's primary care doctor?
So much the same role that they have when medication is provided to someone who's on home hospice care. We give the medication, and there's no oversight. So basically, a prescription for this medication, which is in some ways far less dangerous than the medication that we're sending home for people on hospice care, it goes in the medicine cabinet, and it's used at a time that the person decides they've had enough. And so many people do call in their trusted family physician or their oncologist, the doctor that they have the closest intimate relationship with. They do, on their own, call them in for advice or to be there when they self-administer the medication, but the law does not require that.
Right. So there's no reevaluation that occurs if the patient lives longer than anticipated?
There isn't, no. I mean, and like I said, most people, sometimes it's a fight to get a 6-month prognosis because, as many of you know, in order to enter hospice care, I think that's changing here in New York, but for a very long time, in order to get hospice care, you had to have this prognosis. And I remember as a family member having to advocate for that. And so generally speaking, when someone gets the 6-month prognosis, they're much further along than they were. But there are people who outlive the prognosis, and the data from Oregon and California and elsewhere shows that there are people who significantly outlive the prognosis, but there is no reevaluation. At that point, it's up to the patient to decide when they've had enough. Yes, and then back to you. Yeah.
Thank you. Is there any requirements as who's allowed to prescribe medication or any licensed physician? Because not everybody has the same training.
You're absolutely right. And the treating physician is the one that prescribes the medication. The treating physician has to be someone who is qualified to treat the person with a terminal illness. So it can't be someone whose training doesn't allow them to treat that person. And then there has to be a consulting physician with similar requirements.
I'm sorry for the follow-up. Does this tie into hospice? Do they have to be on board?
Say it again?
Does hospice have to be on board, like healthy or?
No, and in fact, there has been some discussion in the state about whether we should require people to enter hospice before they can ask for medical aid in dying, but some people don't want hospice care. That may be much to the chagrin, I think, of many people who think that hospice provides this invaluable service, but some people don't want that care, and we don't, generally speaking, force people to accept care that they don't want, and so it really shouldn't be a requirement. The thing is that over 90% of the people who access medical aid in dying are in fact on hospice because they've already availed themselves of that. Should we make that a requirement? I think it's probably not a good idea. Yeah. Back here and then to you. Yeah.
One thing I want to say is that I think this is great, but I think we have to do the wrong way. What does the palliative care team do? There needs to be discussion, because I think a lot of patients are going through, and when I'm on the floor, I see them, and I'm saying, where's the family member? Are they involved? It begins with a discussion with the family member, have a the doctors, a back and forth discussion, know what it is, where they are, because many patients don't even know where they are. Or the family members don't even know where they are. So we need to bring in a palliative care team that is strong, that the family can understand, and then we can go to this level. Because unless we get to this phase where there's good communication between the provider and the patient and the family, it's not going to go to the next step, which is that final step.
I could not agree with you more. The legislation actually requires that the doctor who receives a request, an oral request for medical aid in dying, has to go over what the options are and the benefits of palliative care. You may know that the legislature passed a bill called the Hospice and Palliative Care Information Act, which actually does require physicians treating people with a terminal illness to let them know about palliative care. The law isn't strong enough. It's actually not forcing those conversations. But can you force those conversations is kind of a question to ask. Can a law force people to have a conversation? Probably not. But creating an atmosphere where people are willing to talk to their providers openly about what they want can have that effect. And I think that's what we've seen in other states, and I think we can expect to see the same here. Yes?
Is there anything that prevents people from driving to those friendly states to see doctors there?
Reality, a little bit. I mean, there are some residency restrictions in some of the laws, not all. But in reality, it's very difficult for people to do that. I often talk to people who say, well, I've got a plan. I'm going to go to Oregon or I'm going to go to Vermont. 2 years ago, I was working with a professor from NYU who had mesothelioma. And we met for coffee at an Au Bon Pain in Greenwich Village, and he said, my wife and I are moving to Oregon when my immunotherapy treatments stop giving me the benefit that they have been. I think he had received 2 immunotherapy treatments at that point that had extended his life a few months and improved the quality of his life. And I was skeptical because, despite the fact that we have an outlier in a woman named Brittany Menard, who many people may recognize her name. She was a 29-year-old woman who was diagnosed with a glioblastoma, and she did move to Oregon from her home in California, and she sparked the California law's passage. But I thought to myself, Professor Cohen, I wanted to say, it's going to be very difficult. He was already very weak. But in fact, he went in for a scan, and it turned out that his cancer became more aggressive, and he and his wife boarded a plane for Oregon the next day. They had rented an apartment on Craigslist, and they got there, and his wife, who works with us now, described that when he touched down in Oregon, it was almost like a relief. He was in a state that would allow him to do this, and he died 2 days later. He did not have time to set up the relationships that he needed with the 2 providers. It takes a while. On average, it takes 6 weeks to go through the entire process. So by the time someone is that sick, to have the resources, to have the ability to move, it's a barrier. Yeah. Yes?
Yeah, I don't know if I'll have 2 questions there quick. One is a follow-up on the advanced planning. Are any states looking at that? It's
No.
probably very impossible almost to do. The other was about the one you mentioned with an advanced directive related to dementia who didn't want to be treated. Are people permitted to include not allowing other nutrition and that kind of?
It's new. There is a protocol out there now that people are talking about, and I would imagine, like a case that someone brought up before about the nephew, I think you said the nephew flying in, I think that family members would challenge it, but I think it's something that people are interested in doing. And voluntarily stopping eating and drinking can be a peaceful way for people to die, but for others, it's really hard. It's hard to watch a loved one starve to death, and so I think families may try to get involved in stopping something like that. But there is a legal protocol out there now for people to take advantage of.
I do think I remember learning years ago that they have studied whether patients declining of food had an adverse impact on their outcomes and whatnot. And it seemed not to really?
Yeah, there's a lot of research about it now because it's more common, but generally speaking, the pain and the discomfort of stopping eating and drinking subsides after 2 days, but some people develop what's called terminal agitation, and they become violent, they become, it's not pleasant for their families, and maybe for them, who knows, you don't really know at that point, but for their families, it's pretty torturous to watch. Not for everyone, but for some.
I just will give you a short vignette. My godmother practiced law in Alaska for 50 years, and she had twin sons. And she had everything written to the letter because law was her profession. And after she had a stroke and became a phase-out, the two of them, I actually had to fly to Alaska to keep them from hurting each other. Because one wanted to do exactly what she said, and the other one wanted to try and get her to change her mind. And the only word I heard her ever say after she had the stroke is when the one who wanted to feed her and do a tube feed and do this, and she asked him, and both of us were there, and the only time she spoke was to say aloud no to him about tube feeding and artificial hydration and so forth. So even with everything written, you could have disagreement, but it's still better to have your healthcare proxy. And all food and fluids were discontinued. I tried to keep her from not to give fluids, but she wouldn't. She said, I don't want anything. When I can't talk and walk and be independent, she was 92. I don't want to be here. And she died a week later. But that's the way she wanted to die.
Yeah.
She just wanted to be finished.
Right. Families, death and dying can bring out the absolute best in families and the absolute worst. That's why it's important to have conversations, not just to put your wishes in writing, but also to speak them and to have those conversations both with your family and your providers. The other thing is most people think that they have to choose a certain kind of person as a healthcare proxy. So I'm an only child, and my mother always jokes, well, you have to be my healthcare proxy, you're going to pull the plug on me. And I say, you don't have to choose me as your healthcare proxy. I would pull the plug on you, but if you don't want that, then you should choose your best friend. I'm joking, of course. I mean, maybe I would pull the plug, but only if she wanted. So, yeah. Yes?
Although it's very difficult to require these conversations can be incentivized. And I just want to point out that, especially since we have a couple of our district representatives here, that the new state program for payment for Medicaid and uninsured care involves an incentive for discussions about advanced care planning.
That's right.
And those of us who are involved in primary care have actually, over the last year, initiated discussions at least about naming a healthcare proxy, which is, I guess, step one. But we've gotten from a point where we were at about 5% to a point where we are just about over 50% at this point.
That's amazing.
So I think that healthcare movement that can incentivize any kind of conversation surrounding death, probably will help the cause that you're discussing, as well as the cause of other dying patients.
I think you're right. That's why that provision in the Affordable Care Act was so important, so that people could be reimbursed for that time.
Right, so that one lost, but here in...
No, it's actually, my organization stayed in DC. It wasn't part of the Affordable Care Act, but the Centers for Medicaid and Medicare actually adopted the rule a couple years after.
For independent conversation.
Yes, that's right.
Yeah. To take up a whole visit, yes.
But I think the state does a better job anyway, so,
right.
yeah.
A little bit more intimate.
Yeah. Other questions, thoughts?
Just to pick up on that, the physician who wrote the handbook for veterans on end-of-life decision-making probably 10 years ago or so now, was actually the subject of death threats after the death panel conversations. Wow. And really has become much more quiet. One of the best geriatricians I've ever worked with who does ethics. And this was, again, about empowering veterans to think about what was important to them at the end of life, and he got death threats after the death panel Affordable Care Act conversations.
If I could say one more word before I wrap up, and that is, a couple of you asked in different ways, what are the barriers? There really is a perception in Albany that communities of color are opposed to this bill. And we've found through polling and through independent conversations and our work at the state fair last summer that that just is not the case. And so if you are inclined to support this, I can't emphasize enough how much your representatives in Albany need to hear that. I can tell you that Assemblymember Rodney's Bichotte, for example, who represents my old hometown, Flatbush area, is opposed to this bill, and she needs to hear from people. We don't, you know, again, I'm not calling people out to because they're wrong. I think she feels right in her heart about this, but she needs to hear from constituents. So if you're inclined to support this, we need you to let your voice be heard. So thank you for giving me this opportunity.
Thank you very much. And I want you to make one more announcement.
Yeah.
I happen to have met with somebody yesterday who used to be on your board. But you need to tell people what to do if they want to get engaged.
Sure.
If they want to, and to sign the petitions,
Yeah.
and any way that they can be
Yes,
engaged,
yes.
you need to let them know about.
So the petitions are there. If you sign the petition, you will be put on our mailing list, and I will be emailing you to let you know about what options for action exist. Notices about the public hearings, when lawmakers need to hear from you. There's an easy tool on our website. This is like the lowest threshold thing you can do. You can go to www.compassionatechoices.org New York, and it says tell your lawmaker. And it's a click, and all you do is fill out your name. You can write a few words about why you care about this or not, and click send, and the message goes right to your lawmaker's inbox, both your senator and your assembly member. We post all the time about our activities on Facebook, and we also tweet when it occurs to us to tweet. So there are different ways to follow us. Thank you.
Thank you, everyone, for coming.